sure. So the numbers have doubled.
Okay, thanks everyone. Welcome to today's Rheum 101, Rheumatology for Non-Clinicians. For those people watching online, we're coming to you from the University of Manchester. So just a quick recap about what Rheum 101 is, and firstly what UK Rheum is. So UK Rheum is the UK Research in Musculoskeletal Epidemiology Network, and this is a national collaboration between 8 epidemiology centres, those listed on the slide, and we're supported by Arthritis Research UK as part of the Centre for Epidemiology here at the University of Manchester. And Rheum 101 provides accessible introductions to rheumatology topics for non-clinicians. This was an idea that came from the UK Rheum Statisticians Network, and it's really here to address the fact that we felt there were lots of opportunities for training in methodology for people working in this field, but for those of us without a clinical background, not too many opportunities to learn about the diseases themselves that we're working in. So today we're broadcasting live on YouTube, and a recording of today's session will be available via the same link. We had 2 topics lined up for today. We had gout with Ed Roddy and and polymyalgia rheumatica with Toby Halliwell. Unfortunately, Toby can't make it today due to unforeseen circumstances, so our sole speaker today is Ed Roddy on gout. We've got 20 minutes per topic, or 20 minutes for our sole topic today, and then we've got at least 10 minutes for questions afterwards. People in the room can ask their questions in the usual way. People watching online can submit theirs using the hashtag Rheum101 on Twitter, or using the rheum101@manchester.ac.uk email address. There is a slight delay of about 20 seconds or so between what's happening here live and as it appears on the stream. So if people watching live do want to submit questions, we ask they do that in good time. We're really keen to get feedback on today's session. People in the room can fill in a paper feedback form, and for those watching online, either live or later, there's a link on the slide there where you can give your feedback on today's session. So that's all I've got to say. I'd just like to then introduce today's speaker, Dr. Ed Roddy. Ed is a rheumatologist and a reader in rheumatology at Keele University, and he's speaking to us about gout today, and Ed did his PhD on the epidemiology of gout. So Ed, over to you.
Okay, thank you, Jamie, and I'd like to thank both you and UK Rhyme for the opportunity to be in Room 101 today. So I'm going to speak to you about gout, which is one of my favourite topics, and what I'm going to try and cover over the next sort of 20 minutes or so is a little bit about the epidemiology, about the pathogenesis of gout, which we understand very well, and about the reasons why people get it. I'll then cover the clinical presentation of gout, how it affects people who have it, how we diagnose and investigate it, and finally I shall cover the principles of treatment. So gout is the most common inflammatory arthritis, and the most recent prevalence estimates in the UK from the Clinical Practice Research Data Link, which many of you will be familiar with, from 2012 estimate that 2.5% of adults in the UK have gout, so that's 1 in 40 people. You'll see from the slide on the top that gout is more common in men than women, shown in the blue compared to the red, and it becomes more common as people get older. Men typically start to develop gout from the age of 30 onwards, although we do sometimes see it earlier than that, whereas women, it's very rare for women to get gout before the menopause. Although after the menopause, women do start to catch men up. Having said that gout is the most common inflammatory arthritis, though, there is one key difference between gout and the other common inflammatory arthritides, such as rheumatoid arthritis, and that is that gout is managed mostly in primary care. So most people with gout are managed entirely by their GP, and they're never seen by a hospital specialist, such as a rheumatologist. So in terms of the pathogenesis then, gout is a true crystal deposition disease, which is caused by the presence of monosodium urate crystals. And you can see here monosodium urate crystals, these beautiful, bright, twinkling, needle-shaped, negatively birefringent crystals. And every single clinical manifestation of gout can be explained by the presence of monosodium urate crystals and what's happening to them. So we have a very relevant and very well understood pathogenetic agent in this disease. Gout is also a metabolic disease in which elevated levels of urate in body tissues are an essential prerequisite for the development of gout, and elevated serum urate levels is referred to as hyperuricemia. As levels of urate rise in body tissues and body tissues start to become supersaturated with urate, crystal formation and deposition occurs in the tissues in and around joints, but in other tissues as well. Also important to realise when I come on to talk about treatment that if we can lower serum urate, then we can cause crystals to dissolve, so we can remove the pathogenetic agent. Once crystals are formed, they can present in a variety of different ways. So the most classical and most dramatic way is with an attack of excruciating joint pain affecting a single joint, most commonly the first metatarsophalangeal joint at the base of the big toe here. Gout can also present with lumps of urate, which often have this characteristic yellowish or white discoloration, which can be seen in and around joints, and these are called tophi. And the third presentation is with a erosive, deforming, inflammatory polyarthritis, which can cause chronic joint pain and disability, and I shall come back to that a little bit later on. So having said that urate is so important, where does urate come from? So urate is formed from the natural breakdown of our genetic material from our DNA. And those of you who can remember any biochemistry might remember that a key constituent of DNA are the 4 bases: adenine, guanine, thymine, and cytosine. Adenine and guanine are purine bases, and thymine and cytosine are pyrimidine bases. And it's the purine bases, adenine and guanine, that are broken down to generate urate by a series of complicated metabolic steps. So urate is produced endogenously, but we can also derive urate exogenously from our diet. And alcoholic drinks, particularly beer, and also foods such as red meat and seafood can also be a source of urate. So to think about purine metabolism in a little bit, but not a lot more detail, the critical steps in purine metabolism from a clinical point of view are these last 2 steps, where hypoxanthine is broken down to xanthine and xanthine to urate. And the reason that these steps are so important are that these are the steps that are catalyzed by the enzyme xanthine oxidase. And it's xanthine oxidase that is inhibited by allopurinol, which you may know is one of the most common drugs used to treat gout in the long term. Once urate is formed, the body can't break it down any further. So 2/3 of urate is excreted by the kidney, 1/3 by the gut. And as I've already alluded to, when body tissues are supersaturated with urate, crystal formation can occur. So it perhaps won't surprise you to learn that because as 2/3 of urate is excreted by the kidney, the vast majority of people, around 90% of people who have high urate levels or have gout, get it because their kidneys don't excrete sufficient urate in the urine. So this slide shows our sort of classical understanding, if you like, of risk factors for hyperuricemia and gout. So common comorbidities such as hypertension, insulin resistance that's seen pre-diabetes, obesity, and metabolic syndrome are all independent risk factors for the development of hyperuricemia and gout, as are excess alcohol consumption, particularly beer, and excessive consumption of purine-rich foods. Diuretics and other drugs, but diuretics particularly, are also an independent risk factor for hyperuricemia and gout. Hyperuricemia is a risk factor for the development and progression of chronic kidney disease, but chronic kidney disease itself, in turn, can lead to the exacerbation of hyperuricemia. And both hyperuricemia and gout are risk factors for nephrolithiasis, that's renal stone formation, kidney stone formation, and also cardiovascular disease. So you can see here that the relationships between hyperuricemia, gout, and comorbidity are quite complex and bidirectional. Over the last 10 or 15 years, we've started to unravel some new risk factors for gout. So hyperuricemia is very common in people with obstructive sleep apnea. And as a result, obstructive sleep apnea is an independent risk factor for the development of gout. There's been interest in other dietary factors, and I've picked out just one here, fructose, which has generated particular interest, and certainly excess fructose consumption, particularly in the form of sugar-sweetened soft drinks, is again an independent risk factor for the development of gout. However, hyperuricemia does have some other important functions in the body. It is an antioxidant and is thought to have some neuroprotective effects. So there is some evidence that people with gout are at less risk of developing Alzheimer's disease, for instance, and possibly other neurodegenerative diseases as well. And hyperuricemia and gout are also risk factors for erectile dysfunction, mental health problems, and fracture. So further evidence here of the complex relationships between gout and comorbidities. So then, how does gout present clinically? Well, the hallmark of gout are acute attacks of sudden excruciating joint pain. So acute attacks of gout typically come on very quickly, and they can reach peak intensity certainly within 24 hours and often between 6 and 12 hours. Typically the patient goes to bed symptom-free and then wakes up the next morning unable to put their foot to the floor or unable to get a shoe on. As I've mentioned, the pain is excruciating, and gout is often said to be the most painful type of arthritis. And the joint usually looks inflamed, so it's hot, it's red, it's swollen. And it's usually exquisitely tender to touch. So again, patients often describe not being able to bear the weight of even a bed sheet touching the joint. The other hallmark of gout is involvement of the foot, and particularly the first metatarsophalangeal joint at the base of the big toe. 50 to 70% of people have their first attack of gout at the first MTP joint, and 90% of people will have first MTP joint involvement at some point in the course of their disease. However, attacks don't only affect the big toe. The next most commonly affected sites after the first MTP joint are the midfoot joints and the ankle, and then the knees. Upper limb involvement is less common, but when the upper limbs are affected, it tends to be the elbows, the wrists, and the small joints of the fingers. So joints in the axial skeleton, such as the shoulders, hips, and spine, are relatively uncommonly affected. So the natural history of gout then is often described in 4 phases, although in truth it's probably more of a sort of a continuum rather than direct phases. The first phase is asymptomatic hyperuricemia. So patients can have elevated urate levels for decades and not know it. And then all of a sudden they develop their first acute attack of gout, which, as we've heard, commonly affects the first MTP joint but may affect another joint. And then that will get better. And then the patient will go back to, in their eyes, normal until they have another attack, which may be several months or even years later. And then the patient enters what we call the period of the intercritical period. So the intercritical period describes the period between attacks. And the patient will typically go on to have recurrent intermittent attacks. With the passage of time, attacks often become closer together, and they may start to involve different joints. And whereas early on, gout tends to affect just one joint at a time, as the disease progresses, they may get attacks which involve multiple joints at the same time. And then eventually, untreated, the patient will go on to develop chronic tophaceous gout, characterised by these tophaceous deposits that I mentioned before, but also chronic joint pain and disability and an erosive arthritis. And here are some examples of erosions. And hopefully you can see there on the metatarsal head a very characteristic punched out, sometimes referred to as a rat bite erosion. And again, here in the proximal phalangeal joint, you can see erosive change here, but also at both sites you can see marked swelling of the soft tissues as well. And those findings are very characteristic in established disease, although X-rays are often normal early on. So how do we diagnose gout? Well, gout is most often diagnosed clinically. So if we have a classical attack demonstrating the features which I mentioned on my earlier slide in terms of rapidity of onset, severe pain, redness, heat, swelling and inflammation, and that's affecting the first MTP joint, then gout is by far and away the most likely diagnosis. People often use serum urate to make the diagnosis, but we have to be cautious about this because many people with hyperuricemia never go on to develop gout. So to make a definitive diagnosis, this requires aspirating the joint and then examining the synovial fluid aspirated under compensated polarized light microscopy. And if we do that, we can see the typical crystals which we saw earlier. So the management of gout is typically divided into 2 phases. Firstly, the management of the acute attack itself, and then long-term management. The aim of management of acute attacks is to provide rapid relief from the severe pain and inflammation that the patient's experiencing. And we've got three main pharmacological options to do this: non-steroidal anti-inflammatory drugs, a much older drug called colchicine, which we tend to use in low doses nowadays, and also steroids. And that's all I'm going to say about the management of attacks. The aim of long-term management is to lower serum urate. And we know that if we can lower serum urate back down to pre-morbid levels and keep serum urate levels low, then we can stop new crystals forming and we can cause existing crystal deposits to clear. So with the passage of time, this will clear the body, clear the patient of crystals, and effectively provide a pharmacological cure of the disease. If we can clear crystal deposits, then acute attacks stop. Tophi will shrink in size and will eventually disappear, and we prevent long-term joint damage. And ideally, to lower serum urate, we can combine non-pharmacological and pharmacological measures. So a word about non-pharmacological management first. So one of the most important aspects of managing gout is to educate our patient. And patients should be advised what gout is, about what causes it, about why they've got it, and then made aware of whilst lifestyle management is important and relevant for many people, that they should be advised about the benefits of pharmacological treatment. Lifestyle modification does have a place where people do have relevant risk factors, and we can advise people where relevant to restrict their alcohol consumption, to lose weight, and to reduce the purine content of their diet if they're consuming excessively. But it's important to note that what we're talking about here is restricting excessive consumption rather than total abstinence. And as medical practitioners, we can review people's medications and, if possible, stop or reduce the dose of their diuretic, although often this isn't possible in people with severe heart or kidney problems. So to come back to purine metabolism and xanthine oxidase then, there are two main classes of drugs which lower urate in the long term. First of all, xanthine oxidase inhibitors. So as I mentioned earlier, allopurinol is the most commonly used drug to treat gout in the long term, but there's also a newer drug called febuxostat, and both of these drugs inhibit the action of xanthine oxidase. So in effect, they reduce the amount of urate that the body produces. The other class of drugs are uric drugs, and these drugs enhance excretion of urate by the kidney. These are much less commonly used and tend only to be used in specialist rheumatology centres and are infrequently used in primary care. These drugs are quite old. They've been around for many decades: sulfenpyrazone, probenecid, benzbromarone. But lesinurad is a newer drug and is currently undergoing appraisal by NICE. So up till very recently, the evidence-based guidelines for the management of gout, produced by a variety of different bodies, including the British Society for Rheumatology, recommended offering urate-lowering therapy to people with troublesome recurrent symptoms. So people who are having recurrent attacks of gout in the region of 2 or more in a 12-month period, people who have tophi, people who have chronic joint damage or chronic arthritis associated with gout, or people with uric acid renal stones. However, over the last couple of years, we've seen a bit of a paradigm shift, and the recently revised British Society for Rheumatology and European League Against Rheumatism guidelines, both of which were published earlier this year, advised that whilst we should certainly consider we should certainly be recommending urate-lowering therapy very strongly in people with more troublesome disease, we should actually be considering and discussing the benefits of urate-lowering therapy with every patient at diagnosis, at their first presentation. Gout follows a treat-to-target approach, so we start urate-lowering therapy such as allopurinol at low dose, and we titrate the dose upwards gradually over a period of weeks or months with the aim of achieving a biochemical target, which is a urate level below 360 micromoles per litre. And as I've already mentioned a couple of times, allopurinol is the most common first-line drug, certainly in the UK. Allopurinol can sometimes precipitate acute attacks of gout. So conversely, once you start allopurinol, a patient can be at increased risk of more frequent attacks for a while because of the process of crystal dissolution. And as a result, we sometimes provide prophylactic therapy with drugs such as colchicine or non-steroidals in order to try and prevent those allopurinol-induced flares. So treatment becomes a bit more complicated. So I hope I've persuaded you over the last few slides that we have cheap, effective and widely available treatments for gout. However, unfortunately, the disease is very often poorly managed. So a recent study again from the UK CPRD found that 87% of people with gout fulfilled those criteria for urate-lowering therapy that I mentioned before 5 years after diagnosis. But by this point in time, only 31% had received treatment. So there's a real gap between people's need and the treatment that they're actually receiving. And we know that even amongst people who receive urate-lowering therapy, many of them don't have their treatment sufficiently escalated to achieve a biochemical target that's necessary to bring about dissolution of crystals. So within 1 year of starting ULT, the target urate-lowering level is achieved by only 38% of people in primary care, but actually in rheumatology we don't do much better, and our recent national audit showed that only 45% of people in rheumatology hit that target. Now the reasons for this suboptimal management are both multiple and complicated, and I think to an extent both patients and practitioners are partially to blame for this. And the disease itself is perhaps to blame slightly as well, because attacks of gout are intermittent and episodic. And often patients don't consult for gout when they've had it before and when they know what it is and when they've got their non-steroidals on the shelf at home, they feel it coming on and they can take their tablets and they know that that will make it better. So why bother their doctor? Which is fine, of course, but it does mean that their doctor isn't aware that they're having frequent recurrent attacks which might be abated by urate-lowering therapy. Another important factor is that because of the association of gout with lifestyle and the perception in some people's eyes that gout is a self-inflicted rich man's disease associated with excesses of living, that there's considerable stigma and embarrassment about being diagnosed with gout. And this also puts people off consulting for fear of being told off about their presumed lifestyle, which may or may not be relevant. And as we've already seen, many people get gout for reasons that are nothing to do with lifestyle, but are to do with their comorbidities or their medications. It's also true that patients often receive suboptimal education about gout, and patients' understanding of the disease has been shown to be of critical importance in determining their uptake and their desire to take urate-lowering therapy. And not surprisingly, patients often don't like taking tablets, and often patients would rather find the dietary trigger and remove it. People would rather self-manage through non-pharmacological management if they can, and that's understandable. And it's also likely, given the important association between gout and various different comorbidities, that treating gout may receive lower priority than some other conditions which are perceived to be more serious or life-threatening. And of course, the process for escalating urate-lowering therapy can take weeks or months, so it can take a long time, and it's quite laborious and quite labour-intensive to achieve a target serum urate level sometimes. So we need to find, starting to understand these processes now, we need to find better methods of enabling people to achieve target serum urate levels quickly. So in summary then, gout is a common disease, and I hope I've convinced you that we understand its pathogenesis very well. It's associated with considerable comorbidity, and its clinical presentations are easily recognisable very commonly and often very dramatic. Long-term management of gout should ideally combine both pharmacological and, where relevant, non-pharmacological treatments. And the pharmacological treatments that we have available are cheap and effective. And we can effectively cure gout by lowering serum urate and clear crystals, the pathogenic agent, from the body. But sadly, despite the availability of cheap, effective treatment, gout is frequently undertreated. So thank you very much for your time. I'm happy to take any questions, of course.
Thanks, Ed. I'll just come around here into these microphones while the handheld one warms up. I'm sure there'll be some questions in a moment. I'd just like to start by asking you about, you told us about gout affecting essentially the big toe and that joint at the base of the big toe and the foot, and I guess the kind of to the layperson, that's what we would think about with gout. Why is it in particular that site is the classic presentation of gout?
Okay, so that's an excellent question, and it's one that we don't fully understand the reasons for, but there are a number of different theories. So one commonly espoused theory is that it's partly because the big toe is towards the extremes of the body, and therefore it is cooler than other parts of the body, and we know that urate is less soluble in cooler temperatures. Of course, that doesn't particularly explain why gout should affect the first metatarsal phalangeal joint of the big toe, rather the MTP joints of other toes, or indeed other small joints in the foot. Certainly other theories have been put forward that part of it's due to the fact that the toe is more prone to physical trauma. People quite commonly report that they get attacks of gout coming on after stubbing their toe, but again, that doesn't particularly explain why it should be that one joint. And another explanation is that crystals more easily deposit in osteoarthritic cartilage, and the first metatarsophalangeal joint is very commonly affected by osteoarthritis, and that's another reason. I suspect that in truth it's a combination of these different reasons.
Okay, thanks.
Thank you for that. So I tweeted that gout is rare in women pre-menopause, but after menopause it becomes more common. And someone said, well, I've just learnt that women get gout too. Is that a new finding, or is it just a misconception that women wouldn't have gout?
It's certainly true that women can get gout, but it's very long recognised that gout is rare pre-menopausally in women. It was described, in fact, by Hippocrates, so many centuries ago. And there have been lots of studies looking at the effect of female sex hormones on renal urate handling. So estrogen does have an effect to enhance renal urate excretion, and when that effect is lost at the menopause, then urate levels start to climb. So there is a sort of biologically plausible explanation for this. But certainly women do get gout. And I mean, I talked about stigma and embarrassment, and often women report feeling embarrassed that they've got this disease that is perceived to be a man's disease.
Hello. You talked about treating gout with low doses of allopurinol. Very coincidentally, I've seen a talk 2 years ago at BSR that discussed the doses of allopurinol, and the speaker made a case for starting with higher dosages because apparently people are undertreated and are in more pain than they should be. What's your opinion on that?
Okay, so I think it's very clear that we should start at low dose and titrate the dose up gradually. The most feared side effect of allopurinol is a very severe allergic hypersensitivity syndrome, which can be fatal. And that is certainly more common in chronic kidney disease, but it is also related to the starting dose. So the guidelines are very clear that we should start low, particularly in people with chronic kidney disease, and escalate gradually. And by starting low and escalating gradually, we reduce the risk of severe complications.
So you said that quite a lot of people have sort of high serum urate levels but are asymptomatic. Is there any way of predicting who goes on to then develop gout? And then is there any way that you could try and intervene and stop these patients getting gout rather than waiting until they get it and then treating them? Okay,
so that's a really good question. Historically, if you sort of go back to the sort of 1970s, 1980s, some of the current recommendations for only using urate-lowering therapies in people who have gout, but not people who have asymptomatic hyperuricemia, arose from observations that cases of the allopurinol hypersensitivity syndrome that I mentioned in answer to the last question, many of those were seen in people with asymptomatic hyperuricemia, but not gout. So that's why there has been this reluctance to treat people. In terms of identifying people with hyperuricemia who are at risk of developing gout, I think we've got some way to go with that. Certainly, there have been studies ultrasounding people's joints, and we know that we can see crystal deposits in hyperuricemic people who've never had gout, who then go on to have gout. So you can see crystals before people ever have their first attack. So I suppose that might be one line of possible investigation, but at the moment we're some way away, I think.
I keep on asking questions today. Is there like a clear genetic pathway for gout? And does it overlap with other inflammatory diseases?
Okay, so the pathogenetic pathway, I mean, I've talked a little bit about why people become hyperuricemic and why crystals form once body becomes supersaturated. It's only in the last 10 to 15 years that we've started to get a better understanding of how crystals produce inflammation. And it's been realised that crystals induce inflammation by an intracellular structure called the inflammasome, which is found within monocytes and macrophages. And it's through the action of the inflammasome that interleukin-1 beta becomes activated, and interleukin-1 beta seems to be the key inflammatory cytokine in gout. So, and clearly, IL-1 is important in some other inflammatory arthritides, but for example, TNF is perhaps less important in gout than IL-1.
So you talked about some of the elements that may lead to gout, and so I guess most of us would have heard about the dietary ones already, and you talked about some others. But then you also went on to talk about gout, or you mentioned gout being a marker of other conditions as well. You particularly mentioned about a link with mental health. So do you understand what it is about gout that's a predictor of these other conditions? In
terms of, you mean the sort of physical comorbidities as opposed to mental health, do you mean? Or?
Yeah, so I thought, we have the kind of dietary element leading into gout and comorbidities and things, but also you seem to be saying that gout was a marker of people being on a progression towards other conditions as well.
Yes. So in terms of some of those vascular conditions which are appear to be a complication of gout, so things like erectile dysfunction and cardiovascular disease and chronic kidney disease. So all of those diseases have a sort of vascular flavour to them. It's thought there's been a lot of debate over the years about the role of urate. So whether it's urate or whether it's something specific to gout has been debated. Certainly, I think the general consensus at the moment is that urate does have an adverse effect on renal and vascular function. But also, we're also starting to appreciate that gout actually is not an acute episodic condition. It's a chronic inflammatory disease. So again, if we scan people's joints between attacks, we find persistent inflammation within the joints. And we're very familiar with the concept of increased cardiovascular risk in rheumatoid arthritis and systemic lupus erythematosus that has been attributed to chronic inflammation. And it seems, I think, that the same is true in gout.
So would the clinician treating gout, particularly in primary care, would they be alive to the fact that gout, a diagnosis of gout would perhaps be a flag of an increased risk of other conditions kind of downstream? Would that be taken into account in patient care? Well,
it should be. And the guidelines, again, the revised guidelines have been very careful to make recommendations about screening for cardiovascular risk factors, for example, and treating them where relevant. But as ever, the challenge with guidelines is getting that message out there.
So it strikes me that if you give someone a diagnosis that involves them maybe having to even restrict, not abstain from things like alcohol and red meat, that's quite a brutal thing for people to have to do. Are there guidelines on what you can and can't have, or is it kind of a trial and error management where the patient just has to work out what they're doing? So
there are two sort of subtle aspects to dietary management which often get overlooked, and sometimes people think about dietary intervention as a sort of single thing, but actually there are two aspects to it. So on one hand, there is intervention to prevent to stop consuming things that trigger attacks. And often that's what the patient's most interested in. Can I find the one thing that brings on attacks of gout? And patients often report all sorts of things that they think might be the dietary trigger. The second aspect is restricting consumption of foods that elevate serum urate levels. So the two things are subtly different. The guidelines don't particularly differentiate those two things, and the sort of blanket advice is to restrict alcohol consumption, particularly beer, because beer is very rich in guanosine. So people classically think about red wine as being the worst type of alcohol, but actually it's not. It's beer and then spirits, and moderate wine consumption probably confers little risk of developing gout. And then after alcohol, avoiding foods that are rich in purine, so that's red meat, seafood, shellfish, and also sugar-sweetened soft drinks, so things like cola and lemonade. But actually there are some foods which are thought to be beneficial, so low-fat dairy products, coffee, and cherries, and patients love cherries, so that the message about cherries seems to have disseminated very widely. So.
Okay, thanks, Ed. It's unfortunate that we didn't have Toby with us today for our second plan talk on PMR, but Toby's absence has meant that we've been able to have, I think, an extended question and answer session there. So thanks for your talk, and thanks for bearing with us and answering all our non-clinician kind of stupid questions.
No, it's a pleasure.
Thank you.
Thank you.
It was good. There was a real mixture of, because everyone probably thinks a little bit about gout, and knows somebody that's had an attack, if not had one themselves. And it's nice that a bit of kind of some of those things, some of the kind of common knowledge is actually true.
Yes. Yes.
And it also, confounding a few things as well at the same time.
Yes. Well, I didn't include it here for this audience, but I do after the sort of diet slide, the last modification. My next slide.